Bismillahirrahmanirrahim. Assalamualaikum and hello everyone. The topic that I am going to deliver now is about vestibular evoked myogenic potentials or VEMs. I am pretty sure by now that everyone and each of us here understands well that our linear movements, be it the acceleration or deceleration, are innervated by an oscillate organs, which is the utricle and the saccule in our vestibular systems. For a quick recap, the utricle detects linear motion primarily in the horizontal plane, like when we are in a car moving forward or backward, while the saccule detects motion primarily in the vertical plane, like when we are in an elevator going up or down. So, whenever people encounter a problem with their balance, the function of these oscillate organs can now be clinically measured using the vestibular evoked myogenic potentials or VEMs. VEMs is one of the laboratory tests for assessing the peripheral vestibular functions. VEMs comprise of two. The first one is the cervical vestibular myogenic potentials, or termed as CVEMs. The second one is the ocular vestibular myogenic potentials, or termed as OVEMs. VEMs were first described by Kolbach and Hamagi back in 1994. It is a non-invasive procedure to assess patients known to have vestibular disorder. VEMs are produced following high level of acoustic stimuli, and there are short latency electromyograms, or EMGs, recorded via surface electrodes placed over a tonically contracted sternocleidomastoid muscles, or the SCM, termed as cervical VEMs or CVEMs. CVEMs evaluate the saccular function and the uncrossed vestibule-colic pathway. The pathway begins with the saccular macula via inferior vestibular nerve to the vestibular nuclei, the medial vestibulospinal tract, cervical motor neurons, and ended in the SCM muscles. Kindly appreciate the diagram for the CVEM pathway here, reported by Fife et al. To generate the VEMS response, the stimulations that can be used are the air-conducted sounds, bone-conducted vibrations, as well as the galvanic stimulation. The bone-conducted vibration used can be the B71 or the new bone oscillator, the B81, and mini shaker. Another mode of vibration via the tendon tap using the tendon hammer. The most common for CVEM stimulus modality is the air conduction using tone bursts at 500 Hz. Other parameter that is important for CVEM's recording includes the rise-fall time, bandwidth filter, and number of sweeps. This is a published article reported by Papatanasio et al. Regarding the guidelines for the clinical application of CVEMs, where we can refer in preparing the system setting for CVEMs recording. To start the CVEMs recording, first prepare the skin for the electrode placement by cleaning and applying with new prep skin prep gel using gauze, just like the preparation for ABR procedures. This is our medical officers in our ENT department, Dr. Nisha, with the electrode placement inside. So, place the active electrode at the midpoint of the SCM muscles on each side of the neck. Make sure that they are placed symmetrically. To get the SCM muscles, ask the subjects to rotate to the contralateral sides, meaning if you want to have the right SCM muscles, ask the subjects to turn to the left side so that we can see the SCM muscles prominently. Same goes to the left SCM. Ask them to turn the heads towards the right side so we will notice the SCM muscles on the left side for the electrode placement. The reference electrode is placed on or near the sternum, and the ground electrode is placed on the forehead. All electrode impedances must be kept low of about less than 5 kilo ohm in order to obtain high-quality recordings. CVEM is an ipsilateral inhibitory response. So to record them, it is essential that the SCM muscles to be activated or contracted adequately. There are quite a number of methods to gain the SCM muscle contraction. Two methods that are commonly practiced are: number one, the subjects are in sitting position and will be instructed to rotate their head to the contralateral side of the tested ear. That is, for the right ear stimulation, the subject turned his head to the left and vice versa. This method is sufficient to generate the CVEM responses without early fatigue. For the second method, the subject is in supine position and they are instructed to elevate or raise the head from the bed and rotate the head to the contralateral side of the tested ear. In both methods, the subject needs to be instructed to maintain the position. So CVEMs, remember, it is an inhibitory response. So to record CVEMs, we need a good contraction of the sternocleidomastoid muscles. We won't be able to get the CVEMs recording if the sternocleidomastoid is not adequately contracted. So we may encourage the subject to correct the muscle tension by asking them to refer to the visual feedback given through the EMG level meter displayed on the computer screen. The computer screen is advisable to be placed at the side of the subject's head tent. As you can see from this photo, Dr. Nisha is controlling her neck muscles tension by looking at the EMG level. In case placing the computer screen with the EMG level next to the subject's head tent is not possible, we may also guide the subject in correcting the muscles by using verbal instruction. Whenever needed, to assist the contraction, we may also instruct the subject to push their heads to something, for example, a cushion bar, or simply use our hand and instruct the subject to push our hand during the head rotation, as demonstrated by Puan here. The contraction would last up to 100 or 200 sweeps, or even lower, depending on the setting of the sweep that has been set. Please do not use too many sweeps, as it may cause fatigue to the subject that results in unclear responses. In sitting position, if no or small VEMS response is obtained, make sure that the subject's body is straight and not bending or leaning against the chair. We instruct the subject to sit upright properly and retest the CVEMS recording. The sound stimulation is given once the head rotation started. If you still did not get the CVEMS response, even though the subject's position is correct, the head turning is correct, just be sure or double check that you had clicked the correct ear of testing in the system in case you may forget to do that when changing the ear. Each recording has to be repeated in each ear in order to verify the reproducibility of the CVEMS response. Please also allow or offer rest period to the subject between the testing to avoid muscle fatigue. The response of CVEMS would be the biphasic waveforms that is repeatable and reproducible. The measurement for CVEMS were the initial biphasic waveforms labeled as P1, measured approximately at 13 milliseconds, and N1 measured approximately at 23 milliseconds. The measurement also includes the interamplitude for P1 and N1. The interamplitude for P1 and N1 was determined based on the peak-to-peak measures of the waveform. Another parameter that is useful to be used in the interpretation of CVEMS is the amplitude ratio. The amplitude ratio is calculated as the difference in amplitudes between the ears divided by the sum of the amplitudes in both ears, with the amplitude ratio asymmetry greater than 36% being significant. It is best recommended that each laboratory establish their own normal values before interpreting abnormal CVEMS results. Now let's move to the ocular VAMs or OVAMs. OVAMs were described a decade later after the CVAMs. Unlike the CVAMs, OVAM is an excitatory response. OVAMs can be elicited using the same stimulus as the CVAM, which is the air-conducted sound, bone-conducted vibration, as well as the galvanic stimulation. It has also been reported that using bone-conducted vibration as the sound stimulus will generate larger amplitude of OVAMs response. OVAMs can be recorded by the surface electrodes placed over the inferior oblique muscle during eye gazing upward upon receiving sound stimulation. The electrodes were placed contralaterally due to the cross projection of the VOR. OVAMs evaluate the utricle function and the cross-vestibular ocular pathway. The OVAM test is believed to measure the vestibular function from the utricle macula via the superior vestibular nerve, which then crosses the midline to the contralateral medial longitudinal fasciculus and the oculomotor nucleus. Similar to CVAM procedures, the skin preparation for electrode placement has to be done before the OVAMs recording. So this time we have Dr. Rahim, one of the medical officers in the ENT department hospital Sungai Buloh, with an electrode placement for OVAMs recording. So the standard placement of electrodes for OVAMs recording would be the active electrode is placed on the skin over the inferior oblique muscle beneath each eye in line with the pupil and contralateral eye to the tested ear. This means that the recording from the active electrodes placed at the inferior oblique muscles of the left eye represents the OVAMs response of the right ear, and vice versa. The reference electrode is placed on the chin. Some laboratory place the reference electrode approximately 1 to 2 cm beneath the active electrodes. But for this recording, you may need to switch the reference electrodes between eyes according to the tested ear, especially for single-channel system. The ground electrode is placed on the forehead. All the impedance of the electrode shall be kept below 5 kilo ohms. For OVAMs recording, instruct the subject to look upward at midline and maintain the gaze throughout the recording that took about less than half a minute. The subject's gaze can be controlled by instructing them to fixate on a particular target. You may use sticker that is stick on the wall or ceiling. As you can see here, M.A. Taufik is looking upwards to the sticker stick on the wall. In case you don't have any sticker, you can simply hold a pen approximately 20 to 25 degrees above the subject's eye level, as demonstrated here by Puan Rafida to Dr. Nazil for him to look upward. Even though OVAM is an excitatory response, this fixed eye gaze, which is looking upward, is essential in OVAM's recording. It is because by looking upwards, it brings the belly of the inferior oblique muscles to the surface electrodes so that we will obtain optimal results. This photo shows OVAM's recording using the mini shaker as the stimulus. So you can notice here that the ground electrode is no longer on the forehead, but it is at the chin now. The forehead is being used for the placement of the vibration of the mini shaker. For OVAMs, you don't need the EMG monitoring like in CVAM testing. Please also aware that during the upward gaze, the subject's head does not lift up. Usually when we looked up, we tend to lift up our head as well. So this will decline the OVAM's amplitude or even generate no response of OVAMs. Repeatable and reproducible biphasic waveforms elicited will be considered as suitable OVAMs. The measurements include the latency in milliseconds, labeled as N1, measured approximately at 10 milliseconds, and P1, measured approximately at 15 milliseconds, and the inter amplitude of N1, P1. Some laboratory labeled only the N10, and the amplitude of N10 is measured from base to the N10 peak. Amplitude ratio is also useful in the interpretation of OVEMs with AR over or greater than 34% to be abnormal results. Again, as I mentioned earlier, it is best recommended that each laboratory establish their own normal values before interpreting abnormal OVEMs results. There are some contraindications for recording WEMs. The first one is the conductive hearing loss. Conductive hearing loss will impede the sounds reaching the vestibular organ that cause inadequate level of the sound stimulus to stimulate the auditory organs. For conductive hearing loss cases, bone-conducted vibration will be the best option to be used as the sound stimulus because it bypasses the air conduction pathway. Bone conduction stimulus is also suitable for patients with hyperacusis, as bone conduction gives lower auditory sensation level as compared to high stimulus of tone sounds used in air conduction testing. For CWEMs, another contraindication would be the neck mobility. Patients with limited neck mobility or neuromuscular disorder affecting the sternocleidomastoid muscles may not be able to cooperate for CWEMs testing, as contracting the SCM muscles is essential for the CWEMs recording. Another contraindication would be if you could not notice the SCM muscles, you may not have to proceed with the CWEMs recording as it would affect the results. Clinically, WEMs testing has been studied in various disorders. In patients with vestibular neuritis, the WEMs interpretation enables the clinician to determine the particular affected branch of the vestibular nerve. Studies have shown that the loss of the superior division of the vestibular nerve produce absent or reduced OVEMs beneath the contralesion eye and unaffected of the ipsilational CVEMs. This means that the results of OVEMs is affected, whereas the CVEMs results remain intact for the tested ear. In contrast, a patient with neuritis in the inferior division of the vestibular nerve produce absent or reduced CVEMs in the ipsilational side and unaffected OVEMs. This means that the CVEMs is affected, but the OVEMs results can be obtained normally for the tested ear. Likewise, in patients with unilateral vestibular loss, OVEMs and CVEMs were absent or significantly reduced in the affected ears with large asymmetry between the ears. For patients with bilateral vestibular loss, the recording of both cervical and ocular WEMs will result of absent waveforms in both ears. This is an example of case study of patient with unilateral vestibular loss reported by Manzari et al. The WEMs recording in this study used bone-conducted vibration to stimulate the otolith organs. As you can see here, the graph showed in the left panel is the OVEMs results, while the right panel shows the CVEMs results. If you can notice here, the upper graph of OVEMs results, which represent the right eye or stimulus from the left ear, shows smaller amplitude when compared to the OVEMs results beneath the left eye. Whereas in the CVEMs results, both graphs show symmetry in terms of the P1 and 1 interamplitude. This case indicates of utricular loss in the left side. In another case, as you can see here, from the left panel it shows the OVEMs results. Both OVEMs were present and they are symmetry. This indicates of the normal utricular function. As for the CVEM shown in the right panel, the amplitude of the left SCM is smaller when compared to the right SCM. The result shown here indicates of the left circular loss in the left side. In semicircular canal dehiscence patients, the recording of the VAMS is still possible at even lower intensity, whereas in a normal subject, the VAMS will demolish at lower intensity. For HSgD, here a study reported by Weber et al. That shows results of OVAMS in a case with left superior canal dehiscence. Please look to the last graph on the left panel. When stimulating the left ear using air conduction, it elicits a large ovum underneath the contralateral eye, which is the right eye. The graph in the middle shows the normal ovums result in normal subjects. Weber et al. Also reported a case of Meniere's disease. From the study, the patient is having an advanced left Meniere's disease. For this case, the otolith organ was stimulated using the bone-conducted vibrations at the forehead. The ovum results recording underneath the right eye shows absence of ovum, shown by the black cross there, whereas from the underneath of the left eye, it shows normal tracing of ovum results. Another characteristic of Meniere's disease is that we will obtain larger amplitude when tuning the testic frequency to higher level, specifically at 1000 Hz. To summarize my presentation today, vestibular evoked myogenic potentials comprise of two. The first one is the cervical VAMS or CVAMS. It measures mainly the sacral and its pathway. The second one is the ocular VAMS or OVAMS, measures mainly the utricle and its pathway. The stimulation to elicit both VAMS can be via air conduction, bone vibration, and also galvanic stimulation, with the air conduction sounds being the most common used stimulus. Interpretation of VAMS together with other vestibular testing findings enables clinicians to make accurate diagnosis so that best intervention can be suited accordingly. Before I end my presentation, I would like to express my sincere appreciation to the name listed here for giving me endless support during my preparation of today's presentation. With that, I end my presentation and thank you for your attention.